Assalamu alaikum. Good evening. So we meet again after 9 days. This class was supposed to happen 2 days before. Unfortunately, I was a bit sick, so I could not attend the class as a teacher, as a demonstrator on last Tuesday evening. I hope this class will be a bit different from what you had previously regarding the motor weakness. Definitely, motor weakness is a common symptom, and these symptom can occur in quite variety of diseases. Even in nervous system, you will get so many diseases that may present with motor weakness. So before going to the detail of the motor weakness, we must clarify that your motor weakness we must clarify that motor weakness should never be confused with the term generalized weakness. That is why I use the term motor weakness, because the patient may complain of weakness because of different systemic diseases like severe anemia, endocrine disorders like diabetes, thyroid disorders, electrolyte imbalance, chronic infections, chronic inflammatory disorders, even malignancy. In wide variety of disorders, patient will complain of generalized weakness. So this should not be confused with motor weakness, which means that weakness in the movement of the skeletal muscle or group of skeletal muscles due to disease of the motor system. So motor weakness means there is a problem in the movement of the skeletal muscles because there is a problem in any part of the motor system. So this should not be confused with generalized weakness, which we often found in systemic disorders. Another thing we should clarify before going to the discussion, that is there are two terms, paresis and plagia. Paresis and plagia both actually describe the weakness in medical terms. Paresis means partial motor weakness. That means the limb is still possible to move, but is not as strong as normal condition. That is, movement is possible, but it is weak. And on the other hand, plagia means complete motor weakness, total motor weakness. That means the move is not at all movable. Uh, Conventionally, we measure the weakness by muscle power examination during motor system examination clinically. And when muscle power is 0, it is plagia. And when muscle power is 1 to 4, it is paresis. Normally, the muscle power is 5. So anything below 5 is abnormal. That means motor weakness. And when it is 0, it is plagia. But when it is 1 to 4, it is paresis. So paresis is partial motor weakness, and plagia means complete motor weakness. So before diagnosing any condition, so there are quite a variety of diseases that produce motor weakness. We need to ask ourselves two questions. One is where is the lesion, and number two is what is the lesion. That means I have said that motor weakness results from disease of the motor system. So there are quite a few parts of motor system. So you have to first detect where in the motor system the disease is occurring. And after that, you will now search. Thereafter, you will search that, okay, the disease is in this portion of the nervous system. And then you will look for what are the possible causes of disease in the particular part of the nervous system. So two basic questions must be answered before diagnosing motor weakness. One is where is the lesion, that is the anatomical diagnosis, and what is the lesion, and that is the etiological diagnosis. So let's just go to the where is the lesion question. In fact, motor system consists of upper motor neurons, lower motor neurons, neuromuscular junction, and skeletal muscles. So upper motor neurons consist of pyramidal cells and the pyramidal tract. In fact, pyramidal cells lie in the cerebral cortex in the brain, and their axons form the pyramidal tract, which lie in the internal capsule, then in the brainstem, and finally in the spinal cord as pyramidal tract. So upper motor neurons are present in two structures of the body. One is brain and one is spinal cord. It is very important. So let's check about the lower motor neuron. Lower motor neurons are the anterior horn cells of the spinal cord and the cranial motor neurons of brainstem. And their axons form the peripheral and the cranial motor nerves, and they present in the nerve roots, in the nerve plexus, and then in the peripheral nerves. So lower motor neuron will be found in the brainstem, in the spinal cord, in the nerve roots, the nerve plexus, and finally the peripheral nerves. So the lower motor neurons, which originate from the brainstem, produce the cranial motor nerves. So cranial motor neuropathy is totally a different topic, and hopefully we will have lectures on cranial neuropathy in some other day. So for today's lecture, let's restrict the presence of the lower motor neurons in the spinal cord, then the nerve roots, the nerve plexus, and peripheral nerves. In fact, this is the way a peripheral nerve is formed to supply a limb. It originates from the spinal cord, then it starts as the roots. Before entering into the limb, it forms the plexus, and from plexus, the typical peripheral nerves, the big nerves, come out. So, motor weakness, uh, if someone have this symptom, the lesion could be anywhere in these 7 areas. It could be in the brain, spinal cord, nerve roots, nerve plexus, peripheral nerves, at neuromuscular junction, and even in the skeletal muscle. So anywhere in these structures, within these structures, uh, you can have uh, motor weakness. So how will you determine that where is the lesion, the anatomical diagnosis? In fact, there are 4 basic terms that will clinically help you determining the location of the disease. One is distribution of disease, then the type of weakness, we'll discuss it a few moments later. Then two different things. These are not related to the weakness. These are sensory loss and bladder dysfunction. So among the 4 questions, 2 questions are directly related to the weakness, the distribution of weakness, and the type of weakness. And 2 are not directly related to weakness. In fact, these are separate symptoms, but if they are associated or one of them is associated with the weakness, then they signify the location. So what do you mean? Then the second question is, where is the lesion? Most of the cases, it is finalized clinically with the help of the course of the disease. That means how the disease starts and how does it progress. This is called onset and progression of disease, or the course of the disease. And according to the course of the disease, the pathology, the etiology uh, will be determined. So let's get into the where is the lesion question. We started with the distribution of weakness. Distribution of weakness means which part of the body having the motor weakness. If one limb is affected, it is monoparesis or monoplegia. If uh, both upper and lower limbs of one side of the body are affected, it is called hemiplagia or hemiparesis. If both the lower limbs are affected, it is called paraplegia or paraparesis. And if all the limbs, that means both upper and both lower limbs are affected, it is called quadriplegia or quadriparesis. So these are the typical forms of weakness, patterns of weakness we find in motor weakness patients. That is one limb monoparesis, one-sided upper and lower limbs hemiparesis, both lower limbs paraparesis, and all four limbs quadriparesis. Another term is also important, apart from the number of limbs involved. That is, which part of the limb is or are predominantly involved. Whether the proximal part is mainly involved or the distal part is predominantly involved. And in some other diseases, you will get both proximal and distal parts equally involved. So this is also important. Just for example, the myopathies usually involve the proximal parts of the limbs, and neuropathies usually involves the distal part of the limbs. And brain and spinal cord lesions usually involve both the parts, proximal and distal, equally. So this distribution is also important. Apart from the number of limbs involved, we will also consider within the limb which portion, proximal, distal, is predominantly involved or equally involved. And the second point was the type of weakness. In fact, the type of weakness, we have four basic type of weakness determined by the history and examination. These are upper motor neuron type weakness, lower motor neuron type weakness, neuromuscular junction type weakness, and myopathic weakness. So it indicates predominantly uh, involvement of the upper motor neurons, the lower motor neurons, myopathic, that means the skeletal muscles, and neuromuscular junctions. So there are four basic patterns of motor weakness, and it is determined by clinical examination of the motor power, motor system. And the important points in determination of the basic type of weakness are bulk of muscle, tone of muscle, power of muscle, reflexes that include the jerks or deep tendon reflexes, and plantar response. So in short, these 5 points, in fact, these 5 points are the bulk, tone, power, jerks, and plantar are the key determining factor for classifying the type of weakness, whether it is upper motor neuron type, lower motor neuron type, myopathic type, or neuromuscular junction type. In upper motor neuron lesions type weakness, the bulk is usually normal, the tone is increased, power is reduced. In fact, unless the power is reduced, you cannot call any disease to have motor weakness. The jerks are brisk. It is also called exaggerated. So brisk and exaggerated are synonymous terms. And the plantar is extensor. So if you just ignore the point power, in fact, it will be reduced in any motor weakness. So normal bulk, increased tone, brisk jerks, and extensor plantar indicates upper motor neuron lesion. In contrast, in lower motor neuron lesion, the bulk will be reduced. So reduction of muscle bulk is also called wasting. The tone will be reduced, the jerks will be absent, and plantar will be absent. So in contrast to upper motor neuron lesion, uh, reduced bulk, reduced tone, and absent reflexes, absent jerks, and absent plantar indicates lower motor neuron lesion. Myopathic lesions, uh, they have a distinct pattern. The pattern is the bulk is reduced, the tone is normal, And jerks and plantar, they are normal. That means the jerks will be normal and plantar will be flexor. We all know that there are three types of plantar reflexes: flexor, extensor, and absent. Flexor is the normal plantar reflex. When we have upper motor neuron lesion, it will be extensor. And when we have the lower motor neuron lesion, it will be absent. So in myopathy, as there is no upper or lower motor neuron lesion, the plantar will be normal, which is flexor. It is like that. Neuromuscular junction disorders, and in fact, the disease we encounter in this category is myasthenia gravis, and this disorder it is quite interesting one because in these disorders, the motor weakness is fluctuating. The patient will feel weak sometimes, and then they feel relatively better for the rest of the time. And it is also called fatigable weakness. In fact, when they start doing something, they will not feel the weakness. The muscles will work properly. But after some times, the muscle will start becoming weak, and it will be weaker progressively. So this is called fatigable weakness. In fact, the normal motor examination, which helped us in determining the upper motor type, lower motor type, or myopathic type of weaknesses, uh, will not help at all in detecting this particular neuromuscular junction type weakness. For this weakness, we have to do the bedside fatigability test. So I think this bedside fatigability test is not much important for undergrad students. You just know the term that it is bedside fatigability test, and it is positive in neuromuscular junction disorder. And the most common neuromuscular junction disorder is myasthenia gravis. Another important thing is, despite the weakness, there will be no wasting or no sensory loss. And another important thing for myasthenia gravis is early involvement of the extraocular muscles. So, in most of the patients of myasthenia gravis, the first thing that is detected is bilateral partial ptosis. Uh, After ptosis, the patient usually develops weakness of the limbs, and this weakness is also fatigable. It means weakness is not there at the beginning of any task, but it will uh, occur and it will worse progressively when the task continues. Okay, fine. Uh, so our fourth point of this fourth point to answer the where is the disease was presence of any sensory loss. Yes, sensory loss is not a motor symptom, but if it is present along with motor symptom in the affected limb, we should think of a spinal cord disease or radiculopathy. It means disease of the nerve roots, plexopathy, disease of the nerve plexus, or neuropathy. So disease of the brain uh, that produce motor weakness will not uh, produce any sensory loss in the affected part. This is very important. And bladder dysfunction is found mainly in the disease of the spinal cord, which is also called myelopathy, and cauda equina syndrome. Okay, we will talk about cauda equina syndrome in the later part of this lecture. So before going to the particular areas, just have a recap. Disease of the brain. This is the motor nerves. That means upper motor neurons and lower motor neurons. When they are diseased, what pattern of weakness they produce? In fact, disease of the brain produces upper motor type weakness. Disease of the spinal cord produces either upper motor or lower motor or mixed upper and lower motor type weakness. And disease of the rest of the nervous system, the more distal part of the nervous system, that is the nerve roots, nerve plexus, and the peripheral nerves, they always produce lower motor neuron type weakness. So let's start with the diseases of the brain. So mainly the motor nerves in the brain are the upper motor neurons, and they are the pyramidal cells in the cerebral cortex, in the motor area, that is the pre-central gyrus. And these cells have cell bodies which are located in the cortex, and they have the exons which produce the pyramidal tract, and this pyramidal tract passes through the internal capsule, then through the brainstem, and finally through the spinal cord. So in the brain, we have the pyramidal system. It includes the cerebral cortex containing the cell bodies, and also the internal capsule and the brainstem. Within the brain, it contains the pyramidal tract. So all these structures are part of upper motor neuron. Another important thing is the pyramidal tract crosses to the opposite side at the lower part of the brainstem before it enters the spinal cord. So eventually, uh, the brain actually controls the opposite side of the body, the motor function of the opposite side of the body. It always happens. And another important thing is in the cortex, where the pyramidal cells are present, uh, the upper limb area and the lower limb area are not close together. They are located at quite distant parts. This is just check the homunculus here. This is the motor homunculus. This is the facial area. This is the upper limb area, and this is the lower limb area. So the upper limb and lower limb area, they are not at the same place. So that is why if there is a disease of the brain, it will not affect both the upper and lower limbs together. Disease of the cortex, I'm sorry, disease of the cortex, it will affect either the face and upper limb, which is located here, the representing area, or the lower limb, which is located here. So in cortical lesions, you will have either weakness of the upper limb commonly, or weakness of the lower limb, and this is called weakness of one limb is called monoparesis. So it will be contralateral monoparesis. If you have disease in the left-sided cortex that serve the lower limb, you will have right-sided weakness of the right lower limb. If you have problem in the right-sided facial or upper limb area, then you will have left-sided facial or lower limb weakness. So it is always contralateral monoparesis in the cortical uh, diseases. On the other hand, in the internal capsule, which traverse in the pyramidal tract, which traverse the internal capsule and the brainstem, uh, all the areas are represented in a compact small region, in a very compact, all the fibers, in fact, from the face area, from the upper limb area, from the lower limb area, uh, all the fibers are packed together in a small cross section. So when you have a disease of the disease like this, that fibers from the distant areas, actually they are put together in the internal capsule and pyramidal tract, and in the brainstem it is maintained. Even in the spinal cord, this is also maintained. So if you have a lesion in the internal capsule, you will have uh, as a result, you will have weakness of both upper and lower limbs in the opposite side. This is called hemiparesis. And this is the same case. It happens when you have a lesion in the brainstem, because pyramidal tract is a compact tract, and when it is damaged, both upper and lower limb supplying fibers are damaged. So disease of the brain that involves the internal capsule or the brainstem will be manifested as contralateral hemiparesis. That means weakness of the upper and lower limbs of the opposite side. So lesion in the cerebral cortex produce contralateral monoparesis, upper motor neuron type, and weakness in the internal capsule produces contralateral hemiparesis, upper motor neuron type. And also, there is a differentiating point between the internal capsule and brainstem lesion, because in addition to providing space for the pyramidal tract, it also gives rise to lower motor fibers for the cranial motor neurons. So, in brainstem lesion, in addition to contralateral hemiparesis of upper motor neuron type, we will also get ipsilateral cranial neuropathy. And this term is often called cross paralysis. That means in the head, uh, the weakness is on one side, and in the trunk and in the limbs, the weakness is on the opposite side. This is also called the crossed paralysis pattern. It indicates a brainstem lesion. This is the short form. That means in cortical lesion, we have contralateral monoparesis. In internal capsule lesion, we have contralateral hemiparesis. In brainstem lesion, we have contralateral hemiparesis with ipsilateral cranial nerve palsy, and this is also called crossed paralysis. So what are the then you have what are the common causes of diseases of the brain? The most common cause is stroke. And the other causes are brain tumor and brain abscess. These three are the common causes. So from the history, we can actually have a guess whether this is stroke, tumor, or abscess. In fact, the stroke usually presents suddenly. The sudden onset means whatever the clinical feature is, the maximum symptom and the maximum sign will happen at the onset of the disease, and thereafter it will not increase. This is called sudden onset, and it indicates a stroke. On the other hand, if the weakness is progressively worsening, that means the muscle power uh, progressively decreasing, it indicates a lesion uh, which might be either abscess or tumor. So investigation for stroke patients is CT scan. CT scan is the choice of investigation for stroke patients. And for abscess and tumor patients, the choice of investigation is MRI with contrast. So if you have a brain lesion as presented with hemiparesis, you will just ask whether what is the onset of the disease. If it is sudden onset, then you think this is stroke, and you advise a CT scan of it. And if it is progressive, then you think it is either abscess or tumor, and you advise to go for MRI with contrast. So this is in short. Uh, Now we'll go for the disease of the spinal cord. So in spinal cord, all these structures, that means the pyramidal tract, the lower motor neuron, anterior horn cells, even the sensory tracts, and also the autonomic tracts, all these tracts are actually uh, present within a very small cross-sectional area, a very narrow area. They are packed in a very small area. So disease of the spinal cord will actually affect uh, all these structures at a particular level. In fact, it affects all these structures: the pyramidal tract, the sensory tracts, the anterior horn cells, the autonomic tracts, in both sides. Because spinal cord is a very narrow organ, so if it is affected by any disease, all these structures in that particular level will be affected. That is why in spinal cord lesion, which is also called myelopathy, don't confuse it with myopathy. Myopathy means disease of the skeletal muscles. Spinal cord lesions are myelopathy. There will be symmetrical upper motor neuron or lower motor neuron signs with symmetrical sensory loss and bladder dysfunction. So combination of these three indicates the disease is located anywhere in the spinal cord. Symmetrical upper or lower motor neuron signs, symmetrical with sensory loss, with bladder dysfunction. If it happens symmetrically, it indicates that disease is located in the spinal cord. So this is a myelopathy. In cervical cord disease, that means cervical myelopathy, there will be weakness of all limbs. In the lower limbs, it is always upper motor neuron type because of the involvement of the pyramidal tract to the lower limb. And in the upper limb, it will be either upper motor neuron type or lower motor neuron type, depending on the level of the disease. If it is in the higher part of the cervical spinal cord, then it will be upper motor neuron lesion. And if it is in the lower part of the cervical spinal cord, then it will be lower motor type of lesions. So this pattern of weakness, that is upper motor lesion of the both lower limbs and upper or lower motor neuron type lesions of both upper limbs, is called spastic quadriparesis. Quadriparesis because it involves all limbs, and spastic because it is predominantly upper motor neuron type. Even it is lower motor neuron type in the upper limb, the upper motor neuron signs in the lower limb indicates the predominance of the upper motor neuron structures. So this is called spastic quadriparesis. Along with the spastic quadriparesis, you will also have symmetrical sensory loss and bladder dysfunction in cervical myelopathy. So what lesions usually cause cervical myelopathy? There is a quite a few number of lesions that can cause cervical myelopathy. Most common is a disc prolapse, then cervical spondylosis, spinal cord tumors, transverse myelitis, an inflammatory disorder of the spinal cord, and finally the spinal trauma. And for all these, you can guess the cause from the history. If it is very short history, then the cause is probably a disc prolapse, a transverse myelitis, or a spinal trauma. If it is a long history, then the cause is probably either cervical spondylosis or a spinal tumor. So what may be the cause? The investigation of choice for a cervical myelopathy is MRI of the cervical spine with contrast. Now let's get into the thoracic spinal cord. In fact, the thoracic spinal cord is also called the dorsal spinal cord. So in dorsal spinal cord disease, in dorsal myelopathy, there will be weakness of both lower limbs, and this is upper motor neuron type. It is also called, and in fact it is commonly called, spastic paraparesis. Along with the spastic paraparesis, there will be also sensory loss and bladder dysfunction in the dorsal myelopathy. So dorsal myelopathy is caused mainly by four types of lesions. Pott's disease, which is spinal tuberculosis, then spinal tumors, transverse myelitis, and spinal trauma. So you can remember by the mnemonic 4Ts: tuberculosis, tumors, transverse myelitis, and trauma. 4Ts for dorsal myelopathy or spastic paraparesis. So in spastic paraparesis, history also helps in determining the cause of the lesion, cause of dorsal myelopathy. If it is a very short history, then it is either transverse myelitis or spinal trauma. And if it is a very long history, then it is either Pott's disease or spinal tumor. But whatever the disease is, investigation will be again MRI. In this case, it will be MRI of the dorsal spine with contrast. Now the lumbosacral myelopathy. In fact, the lumbosacral segment of the spinal cord is located along the very small portion of area against the lumbar 1 vertebra. So the lumbosacral spinal cord segments are actually very small. So when there is a lesion of the lumbosacral segments, it will involve the upper and lower motor neurons to the lumbosacral nerves together. So eventually you will get the features of the lower motor neurons. That is why you will have symmetrical lower motor neuron type weakness in both lower limbs if lumbosacral spinal cord is involved. This is called flaccid paraparesis. And along with the weakness, you will have bladder dysfunction and symmetrical sensory loss. So if you have symmetrical lower motor type weakness and symmetrical sensory loss in both lower limbs along with bladder dysfunction, then think of lumbosacral myelopathy, and this is also called the conus medullary syndrome. Remember, this condition is very important to recognize early because this is a neurosurgical emergency. Emergency neurosurgical intervention may save the neurological function of this patient. So this is caused by conditions like disc prolapse, spondylosis, tumors, and trauma. And investigation is okay. Before going to the investigation, yes, disc prolapse, and spinal trauma usually have a very short history. On the other hand, spondylosis and tumor have a long history. So these points in history will help in having a clue to the etiology. But ultimately, the diagnosis is finalized after doing an MRI of the lumbosacral spine with contrast. So for spinal cord disease, the investigation is MRI with contrast of the relevant segment of the spinal cord. Let's get into the disease of the nerve roots. In fact, the nerve roots actually they have two components. One is a sensory component, and the other one is the lower motor neurons. Sensory component supplies the specific part of skin in the limb. It is called a dermatome, and lower motor neurons supplies a particular group of muscles for a particular one or two movements. It is called a specific myotome. So when someone has a nerve root lesion, the nerve lesion is also called radiculopathy. There will be lower motor neuron type weakness in a part of a limb with sensory loss with a radicular pain. So I must mention what is a radicular pain. A radicular pain is a pain that starts or that predominantly that begins in the neck and then radiates to the upper limb, or a pain that begins in the back and radiates to the lower limb. So you can easily guess if there is a cervical nerve root compression, it will produce the radicular pain that will begin in the neck and radiate to the upper limb. And if it is a lumbosacral nerve root compression, that will begin in the back and radiate to the lower limb. So this is the classical feature of radiculopathy. It means the lower motor neuron type lesion in a part of a limb with some sensory loss in a particular part, along with the most important thing is radicular pain. Another important point I should mention here, because there is special type of radicular disease, the radiculopathy. This is called bilateral lumbosacral radiculopathy, because lumbosacral nerve roots are close together uh, below the conus medullaris of the spinal cord, and this portion is also called the cauda equina. So any disease of the spine that affect the cauda equina will cause uh, diseases of the lumbosacral nerve roots, and this will affect them bilaterally. This is also called the cauda equina syndrome, and the symptoms are a bit similar to conus medullary syndrome. The difference is there will be asymmetrical flaccid paralysis. In cauda equina, there was symmetrical flaccid paralysis as well in both limbs, both lower limbs, but in cauda equina syndrome, there will be asymmetrical flaccid paraparesis. Plus, there will be sensory loss and a special type of sensory loss, which is called saddle anesthesia. It means there will be loss of sensation in and around the anus. The perianal region, there will be loss of sensation. And of course, there is always a bladder dysfunction. Like Cora's medullary syndrome, Coda equina syndrome is also a neurosurgical emergency. So let's get back into the usual radiculopathies. So what are the causes of radiculopathies? Mainly the causes are disc prolapse, the spinal tumors, and spondylosis. So disc prolapse is an acute condition, and the spondylosis and spinal tumors are chronic conditions. So if the history is short, think of disc prolapse. If the history is very long, think of spondylosis or spinal tumors. In any case, the diagnosis will be confirmed by doing an MRI of the concerned spine. So the tumors actually need a contrast. So if you are confident that it is not a tumor, you can go for non-contrast MRI. But I recommend that in any case of radiculopathy, please go for contrast MRI, because otherwise you may miss a spinal tumor. Diseases of the plexus. So plexus, it lies between the typical peripheral nerves and the nerve roots. So nerve roots give rise to plexus, and they give rise to peripheral nerves. So plexus are actually the precursors of the nerves before they enter the limb. And plexus contains the lower motor neurons, fibers, and the sensory fibers. So a plexopathy will produce lower motor neuron type weakness of a particular part of a limb if a part of a plexus is affected, or the lower motor neuron type weakness of the entire limb if the whole plexus is affected. And there will always be a sensory loss along with the lower motor type weakness. So there are two main plexuses in the body supplying the limb. One is brachial plexus, another one is lumbosacral plexus. The brachial plexus supplies the upper limb. The brachial plexus is caused by quite a few number of diseases. In fact, if you have a disease of the brachial plexus involving its upper part, there will be wasting, there will be weakness, and there will be sensory loss in the proximal part of the upper limb. If it is in the distal part of the brachial plexus, there will be weakness and wasting of the lower part of the upper limb. And if both upper and lower portions, the entire brachial plexus is involved, there will be weakness of the entire upper limb. So there are the causes. The upper brachial plexopathy is usually traumatic. The lower brachial plexopathy is caused by cervical rib or malignancy of the breast or lung, and also traumatic. The panbrachial plexopathy, usually it is caused by immunological disorder of the brachial plexus, which is called brachial neuritis, and it can also be traumatic. So whatever it is, brachial plexopathy is diagnosed by doing nerve conduction study and electromyography along with MRI of the brachial plexus. The lumbosacral plexopathy is caused by diabetic amyotrophy and pelvic malignancy, and also by trauma. And diagnosis is confirmed by doing an NCS EMG of the lower limbs along with MRI of the lumbosacral plexus. The peripheral nerve diseases, in fact, the peripheral nerves, they also contain the sensory and the motor fibers. So the peripheral nerve lesions, like the plexus lesions, will also have the lower motor neuron type weakness along with sensory loss. Peripheral nerve lesions, when it involves a single nerve, it is called a mononeuropathy, and there will be a limited area of limb affected, and you will have the same lower motor neuron signs and sensory loss in a particular part of a limb. So there is, and it is caused, the mononeuropathies are usually caused by injuries or compression of the nerves. So there are the different examples of the mononeuropathies, like compression of the median nerve at wrist produces carpal tunnel syndrome. Compression of the ulnar nerve of elbow produces hand wasting. Compression of the radial nerve at the back of the arm, it produces wrist drop. Compression of the peroneal nerve around the neck of fibula produces foot drop. So the investigation of mononeuropathy are two. One is nerve conduction study and EMG, NCS EMG of the affected nerve, and another one is ultrasonogram. So ultrasonogram is also helpful in neurological disorders. And when uh, the peripheral nerve disease affects generalized all the nerves, it is called a polyneuropathy. So most of the polyneuropathy cases are actually sensory polyneuropathies. But there are a few causes of polyneuropathy. They can produce predominantly motor weakness rather than sensory polyneuropathy. So we will discuss the only those conditions, those produce predominantly motor uh, deficits, being a neuropathy. Uh, because sensory neuropathies will produce sensory symptoms and there will be hardly any weakness. In polyneuropathy, there will be symmetrical signs and symptoms. There will be symmetrical lower motor neuron signs and symmetrical sensory loss. And in fact, it involves the distal part of the limbs. Another important thing is it involves the lower limbs first and then the upper limbs. So you will get the sign symptoms of lower motor neuron lesion and sensory loss distally in either lower limbs or in all four limbs. So predominantly distal, lower limb, lower motor neuron lesion, symmetrical is diagnosis of polyneuropathy. So these three causes can produce motor type polyneuropathy. One is Guillain-Barré syndrome, also called GBS. Then chronic inflammatory demyelinating polyneuropathy, also called CIDP, and hereditary motor and sensory neuropathy, also called Charcot-Marie-Tooth disease. So the shorter forms are HMSN and CMT. So uh, although there is a long list of etiology of polyneuropathies, most of them produce sensory polyneuropathy. There is hardly any motor weakness. So only these three, the GBS, CIDP, and HMSN produce significant motor weakness. We can distinguish them from the history and clinical examination. So if the disease progression is very rapid, that is over days, it is GBS. If the disease progression is relatively slower, that is over weeks to months, it is CIDP. And if it is very slow, over years, it is HMSN. In GBS, you will not have any sensory loss. In CIDP, you may have some sensory loss. And in HMSN, you will usually have sensory loss. Another important point is space cavus. I'm sorry I haven't delivered any particular picture of space cavus. It is a special foot deformity. So the arch of the foot is exaggerated. This is called space cavus. And space cavus is present only in HMSN among these three causes of motor polyneuropathy. And finally, as it is an inherited condition, HMSN patients are often found to have a positive family history, which you will not get in GBS and CIDP patients. So in this way, from history and examination, you can get the diagnosis of polyneuropathy with predominant motor deficit. But finally, the diagnosis is confirmed with the help of nerve conduction study and electromyography. And sometimes, if it is CIDP or GBS, you can also go for CSF study, which has typical patterns in these conditions. So I hope to have classes on GBS in the near future, so we'll discuss it on that day. Now the disease of the muscles. In fact, the disease of the muscles, as I said, It produces weakness and wasting, just like these are the lower motor neurons. But the difference is it involves the proximal parts of the limbs, and it is always symmetrical, and the reflexes and sensory functions are always intact in myopathies. So symmetrical weakness and wasting involving the proximal parts of limbs with intact sensation and intact reflexes indicate myopathy. So there is a big list of myopathies. The important one are inherited myopathies like Duchenne muscular dystrophy, Baker muscular dystrophy, limb girdle muscular dystrophy, or myotonic dystrophy. Then inflammatory myopathies, this is quite very important because these are often paraneoplastic and associated with internal malignancy. And these two are polymyositis and dermatomyositis. Besides them, there are endocrine myopathies. Myopathies are also found in endocrine disorders like Cushing syndrome and thyrotoxicosis. And finally, the toxic myopathies, myopathies associated with drugs and toxins. Commonly, three groups of drugs can produce myopathy in our country. The most common is steroid, and of course, the statins and fibrates, the lipid-lowering agents. Investigation for a myopathic case, it includes two serum markers, the serum creatine phosphokinase, that is serum CPK, and serum aldolase, and these two markers are raised in certain forms of myopathy. These are raised particularly in inherited myopathies like Duchenne and Becker myopathy, and also in inflammatory myopathies, polymyositis and dermatomyositis. And these markers will be normal in other forms of myopathy. And finally, the two tests, that is the EMG, electromyography, has its typical myopathic pattern in myopathies, and muscle biopsy. So muscle biopsy is another important test for the final diagnosis of myopathy. And the muscle biopsy muscle is tested for histopathology and also immunohistochemistry, the advanced tests for the final diagnosis of the myopathy. Now we will discuss, we are almost at the end of the discussion of the different diseases. We will discuss about the motor neuron disease. This is a very interesting disease because it involves both the upper and lower motor neurons simultaneously. And it is a relentlessly progressive disease. It can be symmetrical, it can be asymmetrical, it can involve the upper limb, it can involve the lower limb, it can involve both upper and lower limbs, it can involve the proximal part of limb, the distal part of limb, even both the proximal and lateral part of limb. So it has no spatial distribution. But the common thing is it involves the upper motor neurons and lower motor neurons at the same time. And it never involves the sensory function and the bladder function. And it also never involves the skeletal muscles of the eye, the extraocular muscles. So these distinctive features makes this disease a very special one. In fact, you will get both upper and lower motor neuron features with intact sensation, intact bladder in a disease called motor neuron disease. And this disease is diagnosed with the help of electromyography. So let's go to the clinical approach now. I think I will take maximum 10 to 12 minutes to complete the lecture. Uh, so let's start with, if someone has a weakness of one limb, monoparesis involving only part of the limb, it could be either mononeuropathy, plexopathy, radiculopathy, or motor neuron disease. So you will have to do two tests, an NCS EMG and MRI of the relevant spine. If it is upper limb, the cervical spine. If it is lower limb, then the lumbosacral spine. Very simple. If someone has monoparesis involving the entire limb, then it is either a brain disorder, a plexopathy, or a motor neuron disease. So what you will do, if you will just check whether the patient has upper motor neuron signs or lower motor neuron signs, and whether the sensory function is intact or not. If the patient has upper motor neuron signs and there is no sensory loss, the lesion is in brain. So just go for the brain investigations. If the patient has lower motor neuron sign with sensory loss, then it is plexus. So go for the plexus investigations. And if the patient has both upper motor neuron signs and lower motor neuron signs with intact sensation, then it is motor neuron disease. So go for EMG. So what do you mean by mixed upper and lower motor neuron signs? It means in the same part of the body, you will have the upper motor neuron sign and the lower motor neuron sign. Like uh, in a wasted muscle, you get increased tone. Uh, you get absent reflex, but plantar is extensor, like this. So this called mixed upper and lower motor neuron sign. So if the entirely monoparesis presents with only upper motor neuron sign and intact sensation, it is a brain lesion. So your investigation will be CT or MRI of brain. If there is only lower motor neuron sign with loss of sensation, the diagnosis is plexopathy. Investigation will be NCS EMG and also, of course, the MRI of the plexus. And if it is combined upper and lower motor neuron signs with no loss of sensation, it is motor neuron disease and the investigation will be EMG. Hemiparesis indicates always a disorder of brain. So in hemiparesis, if it is sudden, consider stroke, go for CT scan of it. If it is progressive, consider brain abscess or brain tumor and go for MRI brain with contrast. Paraparesis, number of causes. Dorsal myelopathy, onus medullaris syndrome, cauda equina syndrome, polyneuropathy, motor neuron disease or myopathy. So big list. But clinically, you can distinguish if someone has upper motor neuron signs with a paraparesis and there is sensory loss up to the trunk with bladder involvement, then it is dorsal myelopathy. So among this list, only dorsal myelopathy will have pure upper motor neuron signs. And also there will be a sensory loss and bladder involvement. So you will go for MRI of the dorsal spine. If someone has symmetrical lower motor neuron signs, sensory loss, and bladder involvement, it is conus medullaris syndrome. So you will go for MRI, but this time it is lumbosacral spine. So symmetrical upper motor neuron signs with sensory loss, disease in the thoracic cord. Go for MRI dorsal spine. Symmetric lower motor neuron signs with with bladder involvement. It is conus medullaris syndrome. Go for lumbosacral spine MRI. On the other hand, if it is lower motor neuron sign and sensory loss, but asymmetrical and bladder dysfunction, this is cauda equina syndrome. In addition to this, there is a special type of sensory loss, cerebral anesthesia. I have already said that is a loss of sensation around the anus. So in that case, you will also have to do the MRI of the lumbosacral spine. Finally, if someone has lower motor neuron signs, predominantly distal parts, along with sensory loss, if present, predominantly distally, and no bladder involvement. Remember, no bladder involvement. It is polyneuropathy, and you have to go for nerve conduction study. If someone has mixed upper and lower motor neuron signs involving proximal, distal, or both part of the lower limbs, but there is no sensory disturbance, no bladder dysfunction, it is motor neuron EMG. If there is signs, that means weakness and wasting of the proximal muscles, intact reflex and sensation, this is probably myopathy, so you should go for the serum CPK, serum aldolase, EMG, and muscle biopsy. Finally, quadriparesis. So also a bit number of possibilities: cervical myelopathy, motor neuron disease, polyneuropathy, or even myopathy. Same, only upper motor neuron signs in the lower limbs with upper plus lower or upper or lower motor neuron signs in the upper limb. with sensory loss and bladder involvement, it is cervical myelopathy. Go for MRI cervical spine. If only lower motor neuron signs involving symmetrically the distal parts of the limbs, and even when the sensory loss is present, it also involves the distal parts of the limbs without any bladder involvement, it is polyneuropathy. So go for nerve conduction study. So quadriparesis, just think that you get the upper motor neuron signs with sensory loss and bladder involvement. It is spastic quadriparesis. Go for cervical spine MRI. But if there is lower motor neuron signs, sensory loss, and these signs are present mainly in the distal parts of limbs, and there is no bladder involvement, it is polyneuropathy. So go for nerve conduction study. Again, like there is combined upper and lower motor neuron signs with intact sensation and intact bladder function. It is motor neuron disease. So go for electromyography. And if we again, if there is myopathic uh, features, that is with weakness and wasting of the proximal parts of limb with intact reflexes and intact sensation and intact bladder function, go for investigation of myopathy like serum aldolase, serum CPK, electromyography, and muscle biopsy. So before ending, this is very important, how to distinguish a neuropathy from myopathy. And this question is often asked in the oral examination, and it is one of the most popular written questions in the final prof. In fact, by this, they actually try to mean how to distinguish between polyneuropathy and myopathy. Because myopathy is generalized symmetrical bilateral, and polyneuropathy is two-step. So mononeuropathy is with myopathy. So the important distinguishing points are the affected part of the limb. Neuropathy is usually predominantly a distal limb disease. Myopathy is a proximal limb disease. The muscle tone is reduced in neuropathy. It is intact in myopathy. The jerks are absent in neuropathy. They are normal present in myopathy. The plantar reflex will be absent in neuropathy, and they are flexor, that is normal in myopathy. Finally, there will be sensory loss in most of the neuropathies, and there will be no loss of sensation in myopathy. So these 5 points are more or less distinguish neuropathy from myopathy, the clinical points. Apart from that, for investigation, if you do nerve conduction study and EMG, you can have the distinguishing points. The nerve conduction study will be abnormal in neuropathy and it will be normal in myopathy. And EMG will show neuropathic features in neuropathy and myopathic features in myopathy. So those 2 points can be added, but don't forget to remember these 5. If you don't tell any of these 5 and go for the investigations, advanced investigations like nerve conduction study and electromyography, those are not good signs. So the basic things should be remembered and should be told first. So I hope this lecture was a good bit long. I hope you got something from this lecture. And I'm really sorry to take such a long lecture. I hope the next lectures will be shorter. Those will be completed within 40 minutes. So see you guys till then, and have a good time. So we'll be meeting next Tuesday, hopefully. Inshallah, in the next Tuesday, we'll have discussion on polyneuropathies and Guillain-Barré syndrome. And mm, till then, take care. Allah Hafiz, and good night. Thank you.